hereditary spherocytosis. And number two, it's going to be related with an autoimmune hemolytic anemia. Like, for example, the ABO transfusion mismatch. So we say that if you get spherocytes, the next thing you want to do is to differentiate. Am I dealing with either hereditary spherocytosis, or am I dealing with an autoimmune disease, hemolytic anemia? So if you want, you can go to the path of confirming hereditary spherocytosis. And since it's a membrane disorder, we give an example of solubility, the fragility test, the osmotic fragility test is a good example of a test that you can give in the sense that you want to do and confirm a hereditary spherocytosis. But if that's not within the choice, then you want to confirm if it's an autoimmune hemolytic anemia. So you then go ahead and do a test to confirm it. For a case here, an answer is going to be antiglobulin testing. Maybe someone can write for us the other name for antiglobulin test, the common name that we've always been given as the answers in the previous questions. What's the other name for antiglobulin test? Maybe we can scroll down as maybe someone writes it. All right, so Combs test. Someone has written it. It's Combs test, yeah. So in the other question, they used to bring it as Combs test as a differential. If you have a spherocytes, what are you going to do? You're going to do Combs test. In this case, they've given it as another name, antiglobulin test. So if you see, the name is just an interchange away. Remember, just as a brief review, that in Combs test, we have a direct Combs test and an indirect Combs test. Maybe for an MCQ purposes, you can be asked, for example, in a case of hemolytic and disease of the newborn, if you want to confirm that there is hemolysis taking place, maybe they can ask you in case of the mother or in case of the child, what type of Coombs test are you going to do for both of them? So in case of the mother or in case of the child. So for the mother, just get this, the mother, you want to do an indirect Coombs test, yeah? But for the child, you want to do a direct Coombs test, yeah? So if it comes as an MCQ, the child is a direct Coombs test because the child is the where the reaction is actually taking place, where you're having both the antibodies and the cells. But then for the mother, she only has antibodies, and hence you need to provide cells for you to be able to visualize that reaction. So for the mother, it's indirect, and for the child, it's going to be direct Coombs test. All right. So the following question 81, the following clinical finding commonly characterizes most acute leukemias. So as you can see, these other nini are going to be related with maybe a specific type of leukemia, or so the question is like, in general leukemia, what happens? Yeah. So in leukemias, what you're going to have is that since you're producing these abnormal cells, your bone marrow is going to be overtaken. So instead of producing normal cells, your bone marrow is going to be producing too much of these abnormal white blood cells. So what happens, as I always say, if you have a question, maybe an SAQ or a spot about a leukemia, if you ask about a clinical manifestation, it's just easy as going to think about what happens in a pancytopenia. Yeah. So let's start with a red blood cell. That you can write anything about an anemia, because in leukemia, you're going to have your bone marrow. It's one of the causes of a bone marrow failure. Yeah. It's hypercellular bone marrow failure. So in anemia, you just write maybe dyspnea and then the headaches and then fatigue and easy, exercise intolerance and all that. You go to the second one, which is leukopenia. While in some sense, if you measure your white blood cells in leukemia, it's going to be high, since the leukemia is the cells that are increasing our white blood cells. but they are not going to be functioning as normal. You're going to have this abnormal, maybe in acute leukemias, blast cells. Yeah. So instead of them functioning well, you're going to have an abnormality in functioning of red blood cells. So what happens in that turn, you're going to have too much infection. And then number three, you're going to have a thrombocytopenia. And so what happens in a thrombocytopenia, which is platelet related, you're going to have a problem with bleeding. Yeah. And for those people who have seen, I've sent the differences in manifestation. If it's platelet deficiency, or if it's a coagulation factor deficiency. So, for example, here in our case, hematolosis is someone is bleeding, but the bleeding is not because of a platelet deficiency, rather it's because of the coagulation factor deficiency. So, hematolosis here will not fall up as an answer for the leukemia. So, the most correct answer will be a mucocutaneous infection, since you're going to have your white blood cells not functioning well. Hence, it's a common feature that happens in leukemia is that you're going to have an infection. So just remember the pancytopenia and what manifests as those pancytopenia, either as an anemia or thrombocytopenia, or maybe the third one, a leukopenia. You can continue. Right. So a 40-year-old is diagnosed with pernicious anemia. Last time we talked about pernicious anemia and the antibodies associated with pernicious anemia. We talked about the antiparietal cells. Antiparietal cells antibodies. So for pernicious anemia, it's just a megaloblastic anemia. Here, what they're trying to see is, are you going to be able to identify in megaloblastic or macrocytic anemia how your MCV is going to be? Yeah. So we said last time, generally 76 to 96 or maybe 80 to 100 femtoliters as normal MCV. So anything below that one will be microcytic. So we can remove trace E as being microcytic, trace A and B as being anormocytic, and even trace D, yeah, as being anormocytic. So A, B, and D will be normocytic. So we only have one trace, which is an MCV of 106 femtoliters, and obviously translating into an anemia with hemoglobin levels being low. So choice C will be the best answer. All right. I'm having question 86. All right. So causes of vitamin B12 absorption, except so we said that one antiparietal cells antibodies, pernicious anemia, you're going to have it. Gastrectomy, diphyllobothrium latem as utilization of vitamin D, and obviously E as terminal ileal resection. You're going to have, as we talked about last time, we said that vitamin B12 is that you require it to be absorbed at the terminal ileum together with the intrinsic factor. Yeah. For gastrectomy, it's more or less like an antiparietal cell, since you're like removing the parietal cells. So in one case, you're having antibodies destroying it. The other sense, you have maybe you've removed the cells. So if you remove your stomach, yeah, is that you're removing your source of intrinsic factor, yeah, and hence you're not going to be able to have the combination of intrinsic factor, vitamin B12 for them to be absorbed, which is an initial step for vitamin B12 absorption. So the best answer here will be the bacterial overgrowth, since the rest are pretty much correct. All right, question 89. So, infection by which by the following is not usually associated with iron deficiency anemia. So normally what it's written within the notes is that for iron deficiency anemia, you're going to have it occurring in a case where you're having a chronic bleeding. Yeah. So if you have a chronic bleeding, that's why it's going to result itself as an iron deficiency anemia. A good example is always given is the hookworms, so Nicata americanus and Ancylostoma duodenale, also Trichuris trichura and Schistosoma hematobium. So for D and E, I'm not sure, though I'll go with D because for E, Intermoeba stolotica, what then we were written in the notes is that it leads to an acute type of blood loss rather than a chronic type of blood loss. But maybe it's how I'm just thinking is that it can lead after some time it can get to become chronic. So I'll also go with D. But for D, I've not found anywhere mentioning that leishmania is going to be related with iron deficiency because you're not losing blood. What leishmania mainly does is that there is suppression of either the bone marrow or number two, you can have the splenomegaly leading to this pooling of blood and the culling effect and all that one leading to decrease of the red blood cells. So for me, I'll go with D, knowing that leishmania does not um, necessarily lead to an related with an iron deficiency. So I'll go with Sama. So question 94. A healthy term infant with blood type A minus is born to a mother of blood type O. Yeah. So this is a second pregnancy and these jaundice and anemia. So the question is, what's the most likely antibody that happens there? So as last time we said that uh, an antibody, so we talk about what antibodies are in the mother that leads to the attack to the child. So we only say that the antibody, if there is an antigen, then you're not going to have the antibody. But if you lack an antigen, then you're going to have an antibody. Yeah. So most of the time, you always think about if you see a mother and a child, you always think to rush with the rhesus. Um, being the most common cause of these complications. But also ABO blood group can lead to these complications, like the hemolytic anemia of the newborn. Yeah. So in case of this one, the mother is going to is lacking the antigen A and B. And as a rule, we said if you lack the antigen, you have the antibodies. If you have the antigen, you lack the antibodies. So the mother is lacking A and B, and hence she's going to have antibodies against A and B. What about rhesus? The mother is going to be rhesus positive. Hence, she has the antigen D, but she lacks the antibodies. Yeah. So you can see that the antibodies against rhesus are what is what that is causing the problem to the child because the mother does not even have the antibodies against the rhesus. Yeah. And the child is blood group A. So if the mother has antibodies against A and B, and the child is A, since the child is going to be attacked by those antibodies against A. Hence, the correct answer is going to be anti-A and B, right? So just as a rule, if you have the antigen, you lack the antibody. And if you have the antibody, if you have the antigen, you lack the antibody. If you lack the antigen, you have the antibody. So the mother here has lacks antigen A and B, hence they have antibody A and B. But she has the rhesus antigen, and hence she lacks the antibodies against rhesus. So the correct answer will be anti-A and B. And we can continue. question 99. So a laboratory test that indicates intravascular hemolysis is going to be. So you know that hemolysis can either be intravascular and extravascular. So a key differentiation that is normally happening. Extravascular means that the hemolysis is not happening within the blood vessels. Hence, it's going to happen within extravascular compartments. And the most common place is going to be the liver or the kidneys because of the sinusoids. So a common feature for extravascular hemolysis that most of the time is not going to be present with intravascular is going to be a hepatosplenomegaly. Yeah. But if you look at intravascular means if there is blood, yeah, it's within blood, yeah. And if something is happening within blood, the most common place of filtering blood is going to be the kidneys, yeah. And hence, whatever is happening as the degradation products, one of them being hemosiderin or even hemoglobin, you're going to have it present within urine. So hemosideruria, hemoglobinuria are going to be a very good distinguishing factor between an intravascular hemolysis and an extravascular hemolysis. So for intravascular, you want to see something happening within your urine. Why? Because it has a way to reach the kidneys through blood, and kidney is a major place where you're filtering your blood. But then for extravascular, since it's not present within your blood vessels, you're going to have it within these other organs, commonly being the liver and the kidneys and the liver and the spleen, and hence you're going to have the hepatosplenomegaly. So if you want to differentiate those ones, a good test that indicates an intravascular hemolysis is going to be a hemosideruria. Alright, so which of the following is least likely to occur with hemophilia A and B? Is least likely to occur. So I want someone to just maybe try, because we've talked about these symptoms of coagulation and symptoms of platelets. Maybe someone can try using the thing that I sent in the picture. All right. So I've already had one answer. Maybe someone else. One more, Majama. One more. So far. So you have to, and those two have gotten it, yeah? So it's a B, BTK. Yeah? So why is D? You see, bleeding. You think about bleeding, and you think that maybe for hemophilia, this person is going to bleed a lot. So there is no delayed bleeding. But if you look at actually the notes and how they have actually framed it, it's not just bleeding, it's bleeding after surgery. Yeah. So if you compare it with a platelet deficiency, for platelet deficiency, you're going to have spontaneous bleeding. Why is that? So you remember that we talked about from previous lessons. We said that for hemostasis, we have those steps. We have the primary hemostasis, secondary hemostasis, tertiary hemostasis, and then quaternary. So for the primary, it's going to be platelets and the blood vessels. So if those ones are actually intact, yeah, so you're not going to bleed immediately. So if you have a cut, your platelets, if you have well platelets and you're having good blood vessels, you're not going to have bleeding immediately. You're going to have the primary hemostasis trying its best to actually come and work out. Then if that fails, then you bring the secondary hemostasis for them to then come to form the fibrin clots at wherever you're actually damaged. Yeah. So delayed bleeding means that you're not going to have that spontaneous bleeding because your platelets and blood vessels have actually taken in charge. And hence, you're going to have a delayed bleeding, meaning at later on is maybe since the platelets have not been well able to actually wonderfully come and do its work, then later on you can start bleeding because you're having an hemophilia A and hemophilia B. Yeah. So the most correct answer is going to be petite. If you look at the differences, it's actually written no. Like it never happens in these coagulation factor disorders. You're not going to have petechiae, and you're not going to have this ecchymosis and the epistaxis. Either you're going to have things like muscle bleeding within your muscles and bleeding within your joints. So here the most correct answer will be petechiae. Maybe for uh, just revision, hemophilia A, B, and C. So what coagulation factors are going to be missing within those ones? For hemophilia A, B, and C. Maybe someone can remind us as you continue. Tunaweza kwenda tolea mate.
Wait, I have a question.
Yeah.
How come, okay, we said it's delayed bleeding, then how come A is correct? Because they said spontaneous joint bleeding.
Yeah, you see, so that one, the concept about bringing about your joints, yeah, how you bring about maybe the concept about bleeding within your joints will be that one. So here, what actually they were trying to differentiate is you're bleeding after maybe a trauma or maybe bleeding after surgery. That's why they were it was actually specified like you're bleeding after trauma or bleeding maybe after surgery. Hence, the difference between a platelet and anemia is going to be the two. But then, so this is like bleeding. If you're cut maybe somewhere, you see, you understand, you're bleeding like after surgery, like umekatwa mahali. So your platelets will come in and deal with that one first, and then come to try and delay it, and hence you're going to have the delayed bleeding. But in case of joints, you're not dealing with platelets, rather you're dealing with the coagulation factors alone. Umeona? So the platelet part and the blood vessels part, the primary hemostasis, you're not dealing with it first. You're dealing with the coagulation factors. So hence you're going to have the spontaneous bleeding within your joints. Iko sawa?
Yeah, thank you.
Sasa. All right, so someone has reminded us we have hemophilia A, which is factor 8, a hemophilia B factor 9, and then hemophilia C factor 11. So those are the factors. So a 15-year-old female has the following blood count: hemoglobin 12, white blood cells is 10, and neutrophils is 30%, lymphocytes is 70, platelets is 180 times 10 power 9 per liter. So this one, I remember Nate actually explained it very well. He said that you don't look at the percentages. Like neutrophil is supposed to be like 40 to 80%. Lymphocytes is supposed to be 20 to 40. Hence, this is going to be a neutrophilia and neutropenia and lymphocytosis. So you look at the values itself. Yeah. If you look at the white blood cells actually here, you see that the white blood cells are actually well distributed. It's well within the range. But if you then do 30% of 10 times 10 power 9, you're going to have your neutrophil values to be 3. And you know the range for neutrophils is 2 to 7. So neutrophils are okay. Lymphocytes, 70. So if you do 70 times over 100 times 10, you're going to have it at 7. And you know the range for lymphocytes is going to be 1.5 to 4.5 times 10 power 9. So with that one, you understand that you're not having a neutropenia, but rather you're having a lymphocytosis. Yeah, that's nice. A lymphocytosis. And a common cause of lymphocytosis is viral infections. Yeah. So there's only one viral infection, and that is okay. I can't say only one, but the most common viral infection known to cause the opposite of lymphocytosis. Maybe someone can remind us. So generally, viral infections will cause a lymphocytosis because of the CD cells are going to try and overcome it. So there's only one virus, HIV. That's nice. So we talked about last time that HIV causes all the penias except one. Maybe someone can also remind us that one as you continue. Mahdi, tunaweza endelea. Sasa eosinophil. So eosinophilia, yeah? We say that there is going to be all the opinions except eosinophilia. So that's nice. All right. So a 30-year-old female is on parenteral and fractioned heparin for deep vein thrombosis. So which of the following is the most appropriate to monitor this therapy? So if you want to do heparin monitoring, you normally use the monitoring for the intrinsic pathway, which is going to be the APTT. Maybe someone for foreign you're going to do your PT, yeah. For foreign it's PT, your heparin is going to be your APTT. I always remember it. PT is for the extrinsic pathway, and warfarin is a synthetic drug, yeah. But heparin it's something that's found within our bodies as well. So it's something intrinsic. So it's going to be for the intrinsic pathway and hence the APTT. All right, question 108. So the following does not account for coagulopathy as seen in HIV and AIDS. And maybe someone can just quickly give us the answer. Facade thrombocytosis. We've just said that in HIV, you have all kinds of opinions except one, eosinophilia. It's the only thing that increases, it's the eosinophils. So thrombocytosis will also be wrong because it's supposed to be a thrombocytopenia. So in HIV, there's all the kinds of opinions except one, which is eosinophilia. Can continue. So this thing is just exactly same question, but now you're supposed to be able to give the lymphocytosis part. So you see, question choice C actually has an neutropenia. So if you take the values 30%, 70%, and you just look at it that way, you can actually write C as your answer. But your lymphocytosis is going to be is actually one of the causes, is the answer here. Right. So which of the following statements below is a statement is a finding expected in hereditary spherocytosis? So you see that for hereditary spherocytosis, you're going to have rather an increase. It's an hemolytic anemia, and for we know that if you look at your bilirubin and the whole metabolism, is that we have three uh, maybe causes of jaundice or increase on bilirubin. We have the prehepatic, the hepatic, and the posthepatic. Yeah. So for hemolytic anemia, what happens? It's going to be a prehepatic, and for prehepatic, what happens is that you're leading to production of a lot of bilirubin that overcomes the function of the liver to be able to conjugate them and also excrete them. Yeah. Hence, for a hemolytic anemia, what happens is that you're having a bilirubinemia, but this is going to be a bilirubinemia of especially the unconjugated cause. Maybe can someone maybe explain to us why wouldn't there be a bilirubinemia, meaning bilirubin found within your urine?
I think it's because We've said it's indirect bilirubin, and indirect bilirubin is insoluble. So there's no way it will be in the urine. Only conjugated is in the urine.
Okay, so that's a great explanation. Another explanation is also that you see when you look at the metabolism, is that unconjugated bilirubin is normally transported together, using albumin. Yeah, and you know that when you want to filter in your kidneys, one of the things that happens is that you're not going to have things that are going to be bound to proteins, plasma proteins being filtered. That's even in pharmacology, you normally explain that things that are normally bound to these plasma proteins are not going to be, filtered through the GFR and need another way to be excreted, like maybe the secretion. So you'll never find the unconjugated type are being found within urine. Hence, you're not going to be having bilirubinemia in case of a hemolytic anemia because you're dealing with an increase in the unconjugated type of bilirubin. Tunaweza endelea. Alright, so someone is asking us to repeat. So I've said that you can't have bilirubin and conjugated bilirubin since tumefika hadi the point we have said that this hemolytic anemia leads to unconjugated bilirubinemia, meaning you're having an increase in unconjugated bilirubin. Yeah. So if you're having an unconjugated bilirubinemia, unconjugated bilirubin is normally transported, using or together or bound to albumin. And anything that is normally bound to a plasma protein, you're not going to find it within your urine. Yeah, because we know that in the kidney you have to have the glomerular filtration. So the filtration is not going to allow anything bound to a plasma protein, especially albumin, to be able to get into the urine. And hence, you're not going to have it in urine. Any kind of, the unconjugated type, you're not going to have it in urine. Hopefully that is good. So you're not going to have choice A, choice B, and choice E because you're not dealing with anything of feeding. And then about the raised levels of haptoglobulin is that you're going to have a decrease. Hemolytic anemia normally results to a decrease in haptoglobulin. Maybe for choice E, hemoglobinuria, we say that uh, these things are going to happen. If you see hemoglobinuria and hemosidenuria, you're thinking of an intravascular type of hemolysis. And if you check out hereditary spherocytosis, are one of the causes of extravascular hemolysis. That's why, even if you look at hereditary spherocytosis, one of the things is you're going to have a characteristic person that is going, or a child is going to have the splenomegaly. And you see that's actually a good sign of an extravascular hemolysis is the splenomegaly. Sasa, so if you have a splenomegaly, it's because it's most likely, it's not always, but most likely you're dealing with an extravascular hemolysis. So hemoglobinuria will not also fall here because hereditary spherocytosis is an extravascular rather than an intravascular. So the most correct answer will be bilirubinemia, but you're now dealing with the unconjugated type. Sasa, we can continue. Sasa, so P. falciparum infection may cause anemia through all the following except hii nimechukua tu directly from the notes. Choice A, B, C, and E are all correct. Yeah. Maybe inhibition of erythropoietin. Rather than inhibition or dealing with erythropoietin, what happens in malaria or in even leishmania and all those ones is that they're leading to cytokines that leads to the depression of the bone marrow rather than inhibition of the erythropoietin itself. It's maybe an antagonist, but not rather inhibition of or maybe targeting erythropoietin itself. So choice D will be the wrong answer here. So a characteristic of chronic myeloid leukemia is going to be so choice E, long-term disease control with tyrosine kinase inhibitors. If you remember, when you look at tyrosine kinase inhibitors, the groups such as imatinib and all those ones, even in pharmacology, it was always written that CML, it's the treatment of choice for CML. Yeah. So characteristic of chronic CML, chronic myeloid leukemia, is going to be a long-term disease for tyrosine with tyrosine kinase inhibitors. Examples of those as I've given, imatinib and its group. So a patient with anemia is reported to have the following: sickle cells, target cells, as well as a polychromasia. So the following test will be recommended. So as they've already shown us, we're having sickle cells. Most likely you're looking at a sickle cell, a trait or a disease. Yeah. So which one is the most likely recommended, isn't it, among this thing? You might want to do a sickling test, but you're already seeing sickle cells. So there's no need for you to go and now, uh, further go and do a sickle cell test while you can already see sickle cells. Yeah. So the best and the most definitive diagnosis for a sickle cell, you always want to go and do a hemoglobin electrophoresis. So hemoglobin electrophoresis will be the most recommended. And maybe someone can remind us, why would polychromasia, what would polychromasia mean? Or in what group of anemia is polychromasia almost always seen? As you continue, maybe in iron deficiency or like a group of an anemia, you're always going to find polychromasia. And maybe what will polychromasia suggest if you see a polychromasia? Tunaweza endelea as we can wait for that answer. Alright, so the one not an essential process in the management of lymphomas is so unessential. So really importantly, we answered two questions like this before, like an important asking an essential or maybe fast process or maybe a crucial process, isn't it? Is that maybe in the process you might want to involve these tests or you might want to involve these processes, but at now it's not an essential process in the management. Yeah. So you want to establish the extent of involvement. You want to investigate for status of major body organs. Has it infiltrated other organs and how are they? You want to do a clinical information, obviously. You want to determine the primary cells involved for classification. Remember, yesterday we said that histology is a really important thing, and one of the things you want to do is you want to check out your cell, which cells are involved. Or maybe do you want to check, are we dealing with a B cell or a T cell type of lymphomas? Yeah. So splenectomy is not that much of an essential process of management of lymphomas. Or maybe among the first things you don't want to go ahead and start doing splenectomy. Rather, you want to now check out and investigate how well have we done until now. Right. So someone has given us the answer that I asked. So in hemolytic anemia is when you have mostly polychromasia. And polychromasia, what it signifies, it's that you're having an increase in your reticulocyte count. So sometimes you can have it in a spot. You're being given, you see those, the new methylene blue or brilliant crystal blue. You see blue and then you're seeing some red blood cells. So at first you can be asked, what is the condition? Maybe you can say polychromasia. And then the next one they ask you, name the test, isn't it? Now that's a reticulocyte count. Mona, the test is reticulocyte count, but the condition that's happening is a polychromasia. And then you can go ahead and now maybe be asked the stains. What are the stains used for this test? New methylene blue, brilliant crystal blue, and then maybe you can be asked name conditions. So instead of writing hemolytic anemia, you'll write now the classes. You'll write sickle cell anemia, hereditary spherocytosis, maybe an autoimmune hemolytic anemias. You can give examples like the autoimmune hemolytic anemias and stuff like that. So, on 19, a 45-year-old female patient with fever had the following blood count: HB being normal, but your white blood cell count is going to be high. Your neutrophils is 90%, your lymphocytes is 10%, and your platelets are normal. So the best interpretation of this is, maybe you can do this, you guys. So someone needs to tell us. Quickly do the maths. What can we consider this? Leukocytosis. That's perfect because of the white blood cells. It's definitely high. Yeah, you're having a leukocytosis. But I want to know neutrophils, lymphocytes. Are they normal? Are they high? Which one is high? Which one is low? Which one is normal? Those percentages. Anyone for neutrophils? Lymphocytes are normal. That's really important. Why do 10% of 20? You're going to have 2 times 10 power 9. And we said for lymphocyte, it's 1.5 to 4.5. So really importantly, lymphocytes are normal. Neutrophils, 90% will be high. Yeah. If you do 90 of 20, you're going to have at least 18. Yeah, 18. So neutrophils high. Yeah. So if you don't know how to apply the percentages into real figures, one can easily go ahead and give answer A as the correct answer, saying this is a neutrophilia, and you can see the lymphocytes are low because lymphocytes are supposed to be 20 to 40%. Then you go with neutrophilia and lymphopenia. But rather the correct answer will be a neutrophil, a leukocytosis. Mona, it's only neutrophils that are high, lymphocytes are actually normal in this case. I can continue. Alright, so platelet function may be interfered by the administration of clopidogrel. So we know antiplatelet drugs from pharmacology, clopidogrel is one of them. Warfarin, something to do with, warfarin, heparin, you want to do with coagulation factors. But then for platelets, you want to do clopidogrel. So B is correct. Tuendelee Mahdi. Sasa
Question 124.
sasa hii ilikuwa nataka kuruka niseme ni ya clinical, lakini tufanye. One will encounter an erroneous low laboratory results in the following. You know that EDTA, what it does as even an anticoagulant, the function of EDTA is for calcium chelation. So you don't want to do measuring calcium in a tube that there is chelation of calcium and utilization of calcium. So you don't want to have, you'll definitely have an erroneous anemia. So for heparin, biochemistry, bicarbonate, you can do it. The fluoride tube, which are the gray tubes, you're going to have glucose. Albumin, you can use the plain tube, potassium, plain tube, but then calcium, you don't use your EDTA, you EDTA tube. So the EDTA tube are the purple tubes, and then heparin are the green tubes. The plain tubes are the red tubes. Sasa a common finding in most are myeloproliferative, 2128. The common finding in most myeloproliferative neoplasms is the following except. So myeloproliferative, examples of myeloproliferative is like the polycythemia vera, is like CML. Actually, CML is classified as myeloproliferative. You talk about the what is it called? Is it myelofibrosis? Myofibrosis or something like that. I've forgotten the other name. So those examples of myeloproliferative neoplasms, where characteristically, if you give this neoplastic drugs, and it's not just for that on most of the diseases. If you're treating someone patient with cancer, if you give them those ones, you're leading to a destruction of cells, and those cells contain high levels of uric acid, and hence you're going to have a hyperuricemia. So hyperuricemia is a classical feature. Splenomegaly happens in most of them. Abnormal gene mutations. Maybe someone can remind us. Okay. CML, what are the gene mutations in CML? Gene mutation in CML, maybe. And mutation in polycythemia vera, maybe those two. Hypercellular bone marrow, we've talked about leukemias and lymphomas and all these things. What happens is your bone marrow is hypercellular. Yeah. So a bone marrow failure can either be a hypercellular bone marrow failure or a hypocellular bone marrow failure. So maybe someone can also remind us which one is the classical hypocellular bone marrow failure that happens. So the correct answer is going to be excess plus. For example, if you talk about the difference between a chronic and acute leukemia, a key differentiation is normally with blasts, isn't it? You give the percentage of blasts. If it's above 20%, you say this is acute. If it's below, it's going to be a chronic type. And since you said CML, which is chronic leukemia, is part of the myeloproliferative, it's not going to be characterized by excess blasts. Rather, it's characterized by a lower than 10% blast within your bone marrow. So E is not going to be correct. Rather, it's going to it's the opposite. All right. So someone asks, repeat about hyperuricemia. Is that you see our cells contain uric acid or in different forms within cells. So in when you go ahead in destroying these ones as a treatment by using the antineoplastic drugs, a common side effect is always going to be hyperuricemia. And even if you go back to pharmacology and check out one of the places where you use allopurinol, which is an antiuricemic, gout drugs, is one of the places is normally, I've forgotten its name. It's something crisis, something like that. Where tumor lysis syndrome, it's tumor lysis syndrome, is when you're having cells, you're trying to treat the cells, but then as a result, you're now exposing your blood by the contents of the intracellular compartment. So the intracellular extracellular compartments are different. So if you expose the blood or the extracellular compartment with what the intracellular compartment have, you're going to have definitely a side effect. So hyperuricemia is as a result of that. So about the CML, someone has given us an answer. The BCR ABL gene, chromosome 922 translocation, the famous Philadelphia chromosome. Yeah. So I'll write within the group the common translocations that maybe you need to know are between the two. So you can continue. So here the correct answer will be excess blast. Tunaweza endelea. Right. So we're having an anemia, but what they want you to know here is the MCV. Yeah, na tumerudia normal MCV 76 to 96 or 80 to 100. So here it's way below the normal value, and hence you're having a necrocytic anemia. So at least you're here tunaweza kuelewa. Just go for HB, you're looking at an anemia. Then go next to an MCV. Check out, is it above or below or normal? Sasa, you can continue. I think we have one more question then we're done. Okay, hii tumeshajibu. Tumesema ni AB, anti-AB antibodies. Sasa, I think that's the last